from AIMS New Delhi. Right now, she is working as an associate professor in pulmonary critical care, AIMS Nagpur. I invite you both of you for this session. Initially, I would request Dr. Sryma to introduce to this topic. That will be followed by Ayush doing the presentation. Finally, we'll discuss at the ending. Sorry for the delay because of the small technical glitch. Over to you, Dr. Sryma. Yeah. Ma'am, you have to unmute your thing. Yeah.
Okay, sorry,
Yeah.
am I audible?
Yeah, ma'am, you are audible. Yeah.
Yeah,
Clear.
right. Good evening, everyone. So nice to see you, Dr. Praveen, after a long time. So at the outset, thank you for inviting me to be part of your interesting webinar series. All the topics are pretty interesting, and very well noted. So coming to ventilator-induced lung injury, it's a very relevant topic in terms of critical care because we see the ventilator as a life-saving thing, but most of the time it causes some harm. So it is very important that we realize the harms. So our care should be first directed towards preventing the injury with our intervention. So in terms of that, this is a very relevant topic. So I'm sure Dr. Ayush would do justice and explain to us in detail about what are the mechanisms and how we can prevent ventilator-induced lung injury. So I think Dr. Ayush would be able to screen share right now. Hello?
Yes, I'll just do that, yeah.
I think let's get into the presentation as fast as possible so that we'll have enough time for discussions.
Yes. So, good evening, everyone. I'll be speaking on ventilator-induced lung injury. So, just moving ahead, first a few definitions. So, there are three terms that we need to be aware of. The first is ventilator-associated lung injury. So, whenever you have a patient on a ventilator and he deteriorates with worsening oxygenation, with worsening chest infiltrates, you suspect there is some lung injury going on. You can never be sure whether it's because of the ventilator or there are some other mechanisms at place. Maybe it's a VAP or it's a pulmonary edema. So, at this time, the term that is given is ventilator-induced lung injury. Once you're sure that the ventilator is the cause for the lung injury, it is known as ventilator-induced lung injury. Otherwise, it's called ventilator-associated lung injury. And the last is self-inflicted lung injury. That is because of spontaneous breaths, the patient is injuring his lung. Now, the first question is, does it really exist? Is there something that is known as ventilator-induced lung injury? When I was doing my MD medicine, probably the second year, I was not aware of such a term. So this is just an example where a rat's lung was actually ventilated. Normal rat's lung was taken out and it was ventilated on positive pressure ventilation. So this is at room air in normal lungs when the rat was spontaneously breathing. And after 5 minutes, you can see there is some edema that is developing. And after 20 minutes of ventilation at a peak pressure of 45, you can see what has happened to the lungs. The lungs have become completely edematous. And obviously, there is some injury going on. This means that even in a normal lung, when ventilated at high pressures, there will be some injury that will be going on. The second here is an example of a patient who actually came with ARDS. And you can see the CT is showing bilateral in the basal areas. You have consolidation that is consistent with ARDS. Now, the patient was started on treatment for ARDS. And after a few days, when a repeat scan was done, when the patient was actually better, then you can see what has happened. The regions that were initially involved because of the disease process have healed away, they have cleared, but the regions that were initially uninvolved are now showing signs of lung injury. So this is what ventilator can do to even a normal lung. So let's understand ventilator-induced lung injury by the help of a very simple analogy. So we all are aware of what a sprain is, right? So sometimes we twist our ankle and we say that we have injured a ligament and we have a sprain. So what is the mechanism at play? The mechanism is very simple. The ligaments are made up of collagen fibers and elastin. If you stretch them too much, they will tear, they will get injured. And once there is injury, there is release of inflammatory mediators, and that actually leads to swelling and inflammation and bruising of the angle. So if such a phenomena is existing at a large scale, the similar things are happening at a microscopic alveolar level as well. If you inflate the alveoli too much, if you overdistend the alveoli too much, even the alveoli has collagen elastin, they will get injured, there will be epithelial injury, ultimately there will be alveolar edema, and you will have ventilator-induced lung injury. So why is it important for us to discuss this topic? So any topic becomes relevant once we know that it is widely prevalent, once we know that that disease or that topic affects clinical outcomes like mortality, ventilator free days, ICU length of stay, and most importantly, if we do not know about the topic. So fortunately, all three of these are relevant when we talk about ventilator induced lung injury. So we are all aware about the CDC definitions of ventilator associated conditions or ventilator associated events. So what is that? Whenever a patient is on a ventilator and he has a stability period of 2 days, this means that the patient's oxygen requirement has been stable for at least 2 or more days. Now, if there is any amount of respiratory worsening that is defined as an FiO2 increase of more than zero point 0.2 or a need to increase the P by more than 2, that event is known as ventilator associated event. So what are the different causes of ventilator associated event? The ones that come to mind are the patient could be having, the most common thing that we think is ventilator associated pneumonia. Then we think of pulmonary edema. We think of atelectasis because of either erased intra-abdominal tension or because of the supine position of the patient. We think of mucus plugging. We sometimes think of pulmonary embolism, pleural effusion, pneumothorax, aspiration, or maybe there's an extra pulmonary source of sepsis which is linked to ARDS. But what we do not think of is ventilator induced lung injury. So a patient who has been ventilated either for some other reason like a decreased sensorium develops worsening, even ventilator induced lung injury is a reason for ventilator associated event. So whenever you can rule out suspicion, you label it as a ventilator associated condition, and VILI needs to be considered as an important differential when the patient develops ventilator associated condition. So this was a retrospective study done in China in which they looked at all the people who were mechanically ventilated in their ITUs. So the study included around 19,000 patients who were ventilated, and they saw that among these 19,000 patients, around 1,800 patients had a ventilator associated condition, and out of this 1,800, only 712 patients actually had an infection related VAC. This means that VAP could have been the diagnosis in 712 patients, but around in 1,000 patients, they had worsening on the ventilator, which was not completely explained by an infection. It could be because of pulmonary edema, could be because of ARDS, could be because of aspiration, embolism, etc. But definitely VILI was also at play here. And we can see that in patients who were having this ventilator associated event, their mortality was 20%, which was much higher as compared to the mortality of patients who did not have a ventilator associated event. So if there is worsening on the ventilator, your mortality rates are going to go high. Your median ventilation days are going to go high, 14 as compared to 2. So this was another study, another retrospective study in which the authors tried to look at the incidence of ventilator associated lung injury. So again, they look at patients who at the onset of mechanical ventilation did not have any amount of lung injury. The lungs were healthy, and these patients were included when they worsened on invasive mechanical ventilation. So they tried to exclude ventilator associated pneumonia by looking at the clinical pulmonary infection score. So if the score value was less than 6, they thought that VAP was an unlikely diagnosis. They tried to rule out pulmonary edema by looking at BNP levels, 2D echo, sometimes even doing a pulmonary artery occlusion pressure. And when there was no evidence of left atrial hypertension, no evidence of infection, they labeled these patients as having ventilator-induced lung injury. That is, the patient is having a PF ratio of less than 300, the X-ray showing bilateral infiltrates, but you have no other apparent reason in the form of a pneumonia or in the form of a pulmonary edema. They label these patients having ventilator-induced lung injury. So obviously it's an overkill. Not all the patients would be truly having VILI, but some of them would definitely be having VILI. So we can see that in their setting, out of the 332 patients, they actually thought that 24% of their patients developed worsening, which was because of VILI, and around 12% had pulmonary edema. So even if we assume that this is not a true representation, this is slightly an overestimation, anywhere close to 15 to 20% of their patients would be having ventilator-induced lung injury. And this is about patients who had a normal lung. When we think about patients who already have a compromised lung, like an ARDS patient, these numbers are going to be very, very high. Another interesting thing. So we are all aware about the ARDS net trial. Back in 2000, it was published. It tried to look at the low tidal volume state versus the high tidal volume, 6 versus 12 ml per kg. And we all know about the results. That 6 ml per kg tidal volume showed reduction in mortality as compared to 12 ml per kg tidal volume in ARDS patients. But what I want to talk about is when you put a person on a ventilator, the patient is coming with ARDS, he has a primary pathology, and you have put the person on the ventilator. So you are going to treat the primary pathology with antibiotics or whatever the source of ARDS is, what are the cause of ARDS is, and what therapeutically is your ventilator doing? Your ventilator is basically just giving oxygen and it's removing carbon dioxide. That is the therapeutics of a ventilator. What it can do good for the patient, right? Just give oxygen, take out carbon dioxide. So if the good is only doing gaseous exchange, then why is there a significant difference in mortality when we compare 6 versus 12? This means that 12 is doing some harm and the harm done by 6 is less. You cannot say that 6 is doing some benefit because the benefit is only gaseous exchange. And when we compare the two groups, the CO2 level as well as the oxygen level in the two groups were actually same at day 1 and day 7. So this means that the 12 ml per kg group is actually suffering some kind of harm which is being decreased in the 6 ml per kg group rather than any benefit. This means that the presence of ventilator induced lung injury in the 12 ml per kg group is less as compared to the 6 ml per kg group. So now that we know that VILI does exist, it's important for us to know about it. It affects outcome. Let us understand the pathogenesis, the risk factors, and how we can prevent ventilator-induced lung injury. So the pathogenesis in simple terms is VILI is iatrogenic ARDS. So same pathogenesis will be there. The alveoli will overstretch, which will lead to some amount of epithelial injury, alveolar injury, which will lead to interstitial inflammation, interstitial edema. The alveoli will be flooded. It will lead to surfactant dysfunction, small airway dysfunction, and you will have evidence of bilateral chest infiltrates on the X-ray, and the patient's PF ratio is going to fall. So, what are the mechanisms by which a patient develops ventilator-induced lung injury? So, these are the common described mechanisms. The first is barotrauma, that is increased pressure into trauma. Then you can have volutrauma, you can have atelic trauma, biotrauma, and ergotrauma. We'll look at them one by one. So the first, barotrauma, which is also known as excessive static stress. So pressure is related to stress and volume change is related to strain. So barotrauma is also known as excessive static stress. So it's a very easy concept to understand, I hope, that more the pressure, the alveoli will be under more stress and more the harm. But the question is, which pressure are we talking about? On a ventilator screen, you have a lot of pressure values that you see all the time. You have the P peak, you have the P plateau pressure, you have the P peak minus the P plateau, that is resistive pressure. So what is the pressure that is actually responsible for the barotrauma? So before we understand this, we also need to know that the pressure value that the ventilator shows, what does that value actually even mean? So if we look at this diagram, the value of pressure in the airway can be given as P airway. And if the value of pressure in the pleural space is given as P pleural, then the pressure that is actually functioning across the alveoli, which we know as the transpulmonary pressure, is basically P airway minus the P pleural pressure. So it's not the P airway minus the P atmospheric pressure that is working on the alveoli that is responsible for distending the alveoli. It's the transpulmonary pressure, which is the P airway pressure or the P alveoli pressure minus the P pleural pressure. This means that if the pleural pressure is positive, then even if the airway pressure or the alveolar pressure is high, the transpulmonary pressure is going to be low, right? So we should not be looking at the P peak, the P plat. We should be looking at the transpulmonary pressure, which is the true pressure that is acting across the alveoli, responsible for distending the alveoli. Another thing is what the so transpulmonary pressure is nothing, it's P airway minus P pleural. So another thing is what is the pressure value that the ventilator actually shows you. So if we see if the pressure that is actually responsible for distending the alveoli can be written as P actual, then it should be P that is given by the ventilator screen, that is the pressure that the ventilator is applying, minus the pressure that the patient is generating on his own, that is P muscular. Because they work in opposite directions, I've attached a minus sign here. So this P actual is what is actually working across the alveoli, which is because of the ventilator as well as because of the patient's own conscious efforts. We assume that when the patient is on a ventilator, he is deeply sedated and would not be putting in a lot of effort, and that your P muscular value is going to be close to zero. That is why we assume that whatever the ventilator screen is showing you, that is actually the pressure in the airway. But if your patient is spontaneously breathing, he's not sedated, he's taking sigh breaths, he's deeply breathing, in those cases, the pressure values that is shown on a ventilator is not the true airway pressure values. So let us just look at this example again. So suppose a patient is not intubated and he's breathing normally, right? So his atmospheric pressure is zero, his airway pressure is going to be zero, and the patient, because of his conscious efforts, is generating a negative pleural pressure of minus 10. Therefore, the transpulmonary pressure is 0 minus 10, that is 10. Now, the patient is being put on a ventilator and the patient is sedated. He's only taking passive breaths. There is no active breaths that is being taken by the patient. And suppose the airway pressure or the pressure that is shown on the ventilator screen is plus 10. Since the patient is passively breathing, the pleural pressure is 0. And again, the transpulmonary pressure is plus 10. But now, if the patient is intubated, but he's taking active breaths, this means the patient is generating efforts on his own. So again, if suppose the airway pressure, that is the pressure being shown on the ventilator screen, is plus 10, but because the patient is taking active breaths, his pleural pressure is going to be anything in the minus range, assuming it's minus 15. So therefore, the transpulmonary pressure is plus 25. So your ventilator screen is showing you plus 10, but what is actually happening across the alveoli is plus 25. Therefore, your ventilator pressures are not a true estimate of the pressure that is acting across the alveolar membrane. So this was a study that was done in among patients with normal lung, and they showed that up till a transpulmonary pressure of 30, the evidence of tissue injury was less. And as soon as the transpulmonary pressure crossed 30, that is when the risk of tissue injury increased. And when it crosses 50 to 60, that is when you start developing alveolar aperture as well as pneumothorax. But this is true when the patient has normal lung. When we look at the ARDS net trial and they looked at the mortality and graphed it against the plateau pressure on day one, so they actually showed that with the increasing plateau pressure, the mortality increases, and there was no definite cutoff which could predict that above this the mortality is high and below this the mortality is low. Therefore, in a normal lung, you can safely say that a transpulmonary pressure of 30 is considered to be safe and we should not go beyond 30. But in an injured lung, in an ARDS lung, we are not sure of what the true plateau pressure or the transpulmonary pressure we should keep. Any increase in pressure would be associated with increase in mortality. The second mechanism after barotrauma is volutrauma. So volutrauma is also known as excessive dynamic strain, like strain. So again, the concept is simple to understand. Higher tidal volumes will lead to more alveolar distension and will lead to more harm, right? So this was one study that was done in rats. And what was done is that they had inserted a catheter into the rat's fourth ventricle in order to stimulate the respiratory center. So in the control group, they did not stimulate, whereas in the active group, they actually stimulated the respiratory centers to induce hyperventilation. So what this study showed that in the hyperventilation group, the tidal volume was 9 to 15 ml per kg, whereas in the control group, it was 7. When they looked at the transpulmonary pressure, the transpulmonary pressure was 9.2 and 5.3, not very different and definitely within the safe range. But what they saw was that in the hyperventilation group, 14 out of the 16 rats actually showed abnormal lungs. This means that even if the pressures are normal, even if the transpulmonary pressures are normal, but the tidal volume is high, this will be associated with some kind of lung injury. Therefore, volutrauma can happen even in the absence of raised transpulmonary pressure. If you look at the ARDS net trial, then the ARDS net trial did a subgroup analysis and they plotted the mortality of patients against the value of static compliance. They made 4 quartiles of the lung compliance and plotted the mortality. So as we know, a better compliance suggests that the lung is less bad, the lung is less severely involved, right? But what you can see is that among all the first 3 quantiles, that is, even if the compliance increases, that is, there is less evidence of lung injury, even there was a definite difference in mortality between the low tidal volume group and the high tidal volume group. This means that irrespective of the compliance, and higher tidal volume was associated with more mortality, or we can say that even if the lungs are normal, there is evidence of ventilator induced lung injury when you give higher tidal volumes. But is it the absolute value of the tidal volume that is important, or we should be looking at something else? Right? So is it like 6 ml per kg, 8 ml per kg? Because the kg that we are using here is idle body weight. So should we be using absolute values or should we be looking at some other value? So what we should be looking at is, it is just not the volume, but it is the volume to the available lung ratio that we should be looking at. To keep it simple, is suppose you have a patient with a smaller lung and you have a adult patient with a larger lung. So with the same difference in volume, the smaller lung is going to enlarge much more as compared to the larger lung. Therefore, the strain on the lung will depend on the available lung volume to expand. So this value of tidal volume by EELV, which stands for end expiratory lung volume, or the functional lung volume that is available, is known as strain. So rather than the VT, what we should be looking at is the VT by functional lung volume ratio. If the strain is more, the lung is going to be damaged more because the deformation is going to be more. In a normal lung, this usually does not matter because in a normal lung, the complete lung is available for ventilation. Therefore, if you just use per ml kg, so the kg component is taking care of the size of the lung. But in an injured lung, where a portion of the lung is not available for ventilation, there just using an ideal body weight will not give you a true representation of the patient's available lung for ventilation. And therefore, if you use the same VT equations, you might lead to volutrauma. The next is atelic trauma, which is also known as rapid opening and closing strain. So if you look at this diagram here, the portion on the left actually represents the collapsed lung and the portion on the right represents the open lung. So as you can appreciate, the part of the lung that lies in between the normal lung and the collapsed lung is under a lot of shear stress. And when the lung opens repeatedly and closes repeatedly, this part of the lung is going to undergo damage. Studies have shown that the level of shear stress at these junctions of the open and the closed lung can have pressures which are more than 5 times the actual transpulmonary pressures that we measure. So this part of the lung is under maximal strain as well as maximum stress. Therefore, if repeated opening and closing of alveoli happen, this part of the lung will get damaged. So this is known as atelic trauma. So again, just revising the concepts of volutrauma, barotrauma, and atelic trauma. So barotrauma, it is also known as excessive maximal stretch. That is, if the transpulmonary pressure is more than 30, you are going to have excessive static strain and barotrauma. If your tidal volumes are very high, more than 8 ml per kg, you're going to be having excessive tidal stretch or excessive dynamic strain. And if suppose your alveoli are collapsed and they're opening and closing with every cycle of your breath, you are going to have a reopened strain. So together they lead to ventilator-induced lung injury. Now the concept of biotrauma. So this injury to the lung is not just limited to the lung tissue. Whenever there is going to be injury to the lung, the epithelial cells are going to release inflammatory mediators. These inflammatory mediators will act like chemoattractants. They will get all the inflammatory cells to migrate from the blood vessels into the alveolar lumen, which will again lead to an inflammatory cascade, ultimately leading to the release of cytokines. And these cytokines will go and cause sepsis. They will go and lead to multi-organ dysfunction syndrome. They will go and lead to further lung injury. So ultimately, what happens is this ventilator-induced lung injury, which starts as a localized mechanical injury, it gives rise to a self-perpetuating vicious cycle, vicious inflammatory cascade, and slowly and steadily this keeps increasing and increasing till there is evidence of acute lung injury and MODS. Now there is a new concept that is known as ergotrauma. So ergo, the word stands for energy, right? So till now we have seen that the lung can be injured because of excessive pressure and the lung can be injured because of excessive volume, right? Stress and strain. But what about respiratory rate? So common sense should prevail here. If the lung is undergoing the same stress and the same strain multiple times in a minute as compared to less times in a minute, the injury is going to be more. Therefore, we have to factor in the respiratory rate as well. So this has given rise to a new concept that is known as mechanical power. So what does mechanical power mean? It is the amount of energy that the ventilator is transferring to the lung per unit time, right? And basically it is an integration of the pressure, the volume and the respiratory rate. So we know that pressure into volume gives you energy, and when we divide the energy per unit time, that is the respiratory rate, you get the mechanical power. So this is a volume by pressure graph. So this is how your usual breath starts. Initially, the pressure increases, but the volume does not increase. Then we reach the lower inflection point or the airway opening pressure. Now the pressure increases and the volume also increases till we reach the end of the breath. Then we have an inspiratory pause where the flow is stopped and the pressure drops, and then expiration happens. So if we look at the work, there are three work that is done. The portion D that is there represents the work that is done to overcome the airway resistance, that is to initiate and maintain flow. This is the resistive work. Then there is work that is done to distend the lung, that is to overcome the compliance and the elastic forces of the lung, which is given by C. Right? This is the difference in the P plat and the PEEP, that is known as the driving pressure. And this driving pressure into volume gives you the work done against these elastic forces. And the last work is B, that is the work that is done to expand the functional residual capacity of the lung. So ultimately, mechanical power that can be given by Vt into P inspiratory into respiratory rate. So the true method to determine the mechanical power is actually to look at this area under the PV curve and then multiply it by RR. But this is an extremely tedious process, right? So a lot of authors have tried to derive various mathematical equations that can predict and estimate this mechanical power. So this was the first equation that was given by Gattoni et al., which is a very extensive equation, as you can see, which can estimate the mechanical power that the ventilator is given to the patient every minute. And the most commonly used one is the one that I've highlighted in yellow. This is known as the simplified mechanical power equation. So if you look at this, mechanical power is nothing. It's a multiplication of the tidal volume into the pressure, and the pressure is the P peak minus the driving pressure by 2 multiplied into the respiratory rate, and this is the conversion factor for converting it to joules per minute, 0.098. So the power is directly proportional to the volume, to the respiratory rate, and the difference in the P peak minus the driving pressure. But the fallacy is, to derive this equation, there are two things that have been assumed. First is that the compliance of the lung is constant throughout inspiration, which we know is not true. As the lungs become more and more distended, the compliance will go down, but this assumes that the compliance is normal. Again, the second thing is, this is the power that is being estimated assuming that the patient is under a constant flow pattern. So if you're using an deaccelerating flow or you're using a pressure control mode, not a volume control mode, then this equation of power calculation cannot be used. So this was a study that was done in more than 8,000 critically ill patients, not ARDS patients who were on mechanical ventilation. It was a retrospective study, and they calculated the mechanical power at day 2, and they tried to plot the patient's mortality against the mechanical power. So they were able to show that for every 5 joule per minute increase in the mechanical power, the mortality actually increased. And this increase in mortality was present even if they factored in low tidal volume and low driving pressure states, right? So they tried to look at the mechanical power versus mortality, and they showed that with every 5 joule increase in mechanical power delivered, your mortality is going to increase. They tried to do multiple analysis using different models to remove the confounding factors. In all the different models, the results were the same. You can see the confidence interval is always more than 1 and the p-value is less than 0.05. And when they tried to remove confounding factors like low tidal volume and low driving pressures, even then high mechanical power was associated with mortality. This means that we have to factor in mechanical power when we are ventilating our patients and just not look at the tidal volumes or the driving pressures. So now that we know about VILI, how do we manage VILI? So like I have told you, it's a self-perpetuating vicious cycle, and if VILI has already happened, you have already, the boat has sailed away. So you don't need to manage VILI. What you need to do is you need to prevent it. So we have to prevent each and every mechanism which was causing the lung injury. So the first mechanism was excessive barotrauma, that is excessive static stress. So the first goal is to reduce the pressures. So like we said, the transpulmonary pressure is actually the pressure acting across the lung, and therefore our aim is to keep the transpulmonary pressure to less than 30. But practically speaking, in order to calculate the transpulmonary pressure, I need the pleural pressure. And to know the pleural pressure, I have to put in an esophageal balloon. And in practical cases, we might not have access to esophageal balloon, and also the placement of these balloons are very critical because any dislodgement of the balloon can give you erroneous values. So what we use in common practice is, instead of the transpulmonary pressure, we use the plateau pressure as a surrogate. So plateau pressure, as we all know, it is measured when we give an inspiratory pause. That is, when the flow is zero, then the pressure that is there at the end of inspiration is known as the plateau pressure. So we use the plateau pressure as a surrogate marker for the transpulmonary pressure. But there is one thing that we have to keep in mind. Let's just understand by this example. So in this patient, there is a lung which is stiff as represented by the dark black border, and it is bounded by the chest wall. So in this case, suppose the plateau pressure is 33 and the pleural pressure is 5. Therefore, the transpulmonary pressure that is acting is 28. But if suppose you have a stiff chest wall, the patient is very obese, right? Or the patient is having significant ascites and the chest wall is stiff, then what will happen is, in order to expand this stiff chest wall, the pleural pressure is going to be positive. So now again in the second case, the plateau pressure demonstrated by the ventilator is 33, but the pleural pressure is 25. Therefore, the transpulmonary pressure is only and only 8. Therefore, your plateau pressures might not be a true representation of your transpulmonary pressures in states where you're expecting a stiff chest wall or you're expecting a low chest wall compliance. For example, in patients who are obese, there maybe a plateau pressure of 30 is not true. Maybe you need to go you can go slightly higher on your plateau pressures because your transpulmonary pressures are going to be less than 30. The second goal, as we saw, was to limit the excessive dynamic strain, right? That is to limit the tidal volume. So a physiological normal tidal volume is somewhere in the range of 4 to 8 ml per kg of your idle body weight. The reason we are using idle body weight is because it factors in height, and we know that lung volume actually depends on the height of the patient, right? So 4 to 8 ml per kg of idle body weight is the normal tidal volume. So your goal in most of your patients is to keep the tidal volume to less than 8 ml per kg. This I'm talking about for all patients, irrespective of their cause for intubation. This means a patient with altered mental status has been intubated, his lungs are healthy. Even then, if the patient has been put on a ventilator, you have to keep your VT to less than 8 ml per kg. Otherwise, you will be causing harm. So what about your ARDS patients? So ARDS patients don't have a normal lung, right? When we say we can keep the the tidal volume to less than 8 ml per kg, we are assuming that the entire lung is available for ventilation. Therefore, your strain is going to be less. This is assuming that the functional respiratory capacity or the available lung volume is normal. But what if it's not? Just look at this example. So this is the patient. We can see that the bilateral lower lobes are consolidated. They will not be participating in ventilation. Now, if you give the patient tidal volume, this tidal volume will get distributed to the available lung, which is roughly 80% of the lung. So if you give 6 ml per kg, what you're actually given to this available lung is 7.5 ml per kg, because these lower parts are not contributing in ventilation. They are not getting distended. Now look at this second example, a more severe patient where almost 70 to 80% of the lung has been damaged, and the available lung for ventilation is only this small pocket of lung in the right upper lobe. So now if you give the patient again 6 ml per kg, only 20% of the lung is actually available for ventilation, right? So this 6 ml per kg is going to go only to this region, and this is causing the regional ventilation of more than 25 ml per kg. So imagine the amount of strain that this part of the lung will be undergoing. Therefore, this concept of 6 to 8 ml per kg is true for most of your patients, but when we are tackling moderate to severe ARDS patients, we need better markers to decide regional ventilation. Just using markers of global ventilation may not be accurate. So then what are the better ways to decide? The first way would be imaging methods. We can do a CT scan, see the amount of available lung, and then factor in our tidal volume accordingly. Or we have newer techniques like electrical impedance tomography. I'll come to that later, which can also give you the amount of regional ventilation, and then you can set your tidal volumes. Or there are certain ventilators which allow you to calculate the functional respiratory capacity by the inert gas washout method. Personally, I've never used this and I've never encountered a ventilator with such a algorithm. So practically, what do we do? Or practically, what can we do? So practically, we have to use surrogates for functional lung. We cannot calculate the functional lung, so we need some surrogate markers that will predict the functional lung, right? So what is the surrogate marker that can predict the functional lung available? That is compliance. So we all know compliance is directly proportional to the available lung volume. If the lung volume is more, the compliance will be more. If the lung volume is less, the compliance would be less. So your compliance is actually a surrogate marker of your end expiratory lung volume or your functional lung volume that you have. And we know that compliance is nothing but it's the change in volume by the change in pressure. And the change in pressure is nothing but it's P plat minus PEEP, that is known as the driving pressure. So I can say that the compliance is equal to tidal volume divided by the driving pressure. I hope all of us know how to calculate the driving pressure on a ventilator screen. So this is just a pressure versus time graph. So this top part is the P peak, this is the P plat after an inspiratory pause, and this difference between P plat and PEEP is known as the driving pressure that is responsible for distending the lungs with the tidal volume. So the compliance is directly proportional to tidal volume and inversely proportional to driving pressure. So I can say that if for the same tidal volume, if I give two patients the same tidal volume, if the driving pressure is high, this means I'm dealing with a patient who has a low compliance state and therefore he has a low functional residual lung and therefore there is more strain happening on the lung. So for the same VT, if your delta pressure, that is your driving pressures are high, this means that you are causing more strain on that lung and that VT is not appropriate for your patient. Therefore, instead of just looking at the tidal volumes, what we also have to start looking at is the driving pressures, because your driving pressures are a better estimate of your volume trauma and of the dynamic strain that is what you're causing to your patients. So this was again a retrospective post hoc analysis of your ARDS net trial. So again, this was very interesting. So over here, they have plotted the airway pressure segregated into quantiles, and they have looked at the mortality over here. So in the first graph, if you see, then in all the different patients, the PEEP value is same, but the driving pressure increases. And as we can see in the bottom graph, as the driving pressure increases, the mortality also increases. In the second graph, what they have looked on the third graph, if you see, what they have seen is they have taken patients whose total pressures are same. That is, the plateau pressures for these patients are same, but the PEEP increases and the driving pressure decreases. So we can see that the mortality is actually decreasing. Even if the PEEP is increasing and the total pressures are same, still the mortality is decreasing. And in the second graph, we can see that they have plotted patients who have the same driving pressure, but the PEEP is increased and the total pressure also increases. But you can see that the mortality is same. So what this graph is showing you is that the true predictor of mortality actually in these patients was the driving pressure. When the driving pressure was same as in the second graph, the mortality was same. When the driving pressure was increasing, the mortality was increasing. When the driving pressure was decreasing, the mortality was also decreasing. So what is the safe value of driving pressure? Again, we do not have studies in normal patients, but when we talk about patients with ARDS, as was seen in this post hoc analysis, where they plotted the driving pressure against mortality, they saw that after the cutoff of 15, the mortality actually increased. Therefore, when we are ventilating our patients, we try to keep our driving pressures to less than 15. The third goal was to prevent the atelic trauma, that is to limit the opening and closing strain, right? So to prevent this strain, you can do two things. The first is we do not open the collapsed regions of the lung. So we let the collapsed regions of the lung be collapsed. There will be no strain on these regions, right? But this is not a practical option. The reason being that whenever you give some amount of tidal volume, in order to deliver this tidal volume, the airway pressure will increase, and we know that pressure is evenly distributed throughout the lung, and this increase in airway pressure during inspiration will definitely open up some or the other alveoli. Even if for most of our patients where we ventilate, our airway pressures definitely cross 30. So the pressures are crossing 30, some of your alveoli will get recruited and there will be strain that is happening. So the second option, that is we try to keep the lung open by applying some positive end expiratory pressure. So if your lung is already open, the chances of atelic trauma will decrease. Therefore, to reduce atelic trauma, we have to aim to keep our lung open. That is by applying positive end expiratory pressure. But what is the policy? Can you give the same amount of high P to all your patients? Are all your patients the same? That is not true. For example, look at this patient. So this is a patient with ARDS. Initially, he was at a PEEP of 5. When the PEEP was increased to 45, we can see that most of the regions that were consolidated have now opened up. So this patient has high lung recruitability, and this patient, if you increase the PEEP, you will open up the lung and you will prevent atelic trauma. You will increase the available lung volume for ventilation. But on the second hand, look at this patient, which had a left lower lobe consolidation. Now, if the PEEP was increased in this patient, there was no recruitment at all that happened. And what actually happened was the areas of the lung which was actually normal have now gotten over distended because of an increased PEEP and ultimately led to a decrease in your compliance. So the same PEEP cannot be given to all your patients by just looking at the PF ratio. You have to assess the lung recruitability and then decide what is the PEEP that you should give your patient to reduce atelic trauma. So this was an interesting observation that was made. So there were three major trials, that is the ARDS NET trial, the LUF trial, and the EXPRESS trials, which compared low PEEP states to high PEEP ventilation and tried to plot mortality. In none of these trials, they were actually able to show that high PEEP will reduce mortality. But what this post hoc analysis showed is that they divided patients into two categories. In patients in which the PEEP was actually increased, and in patients in which the people actually decreased. And they plotted the probability of death to the change in the PF ratio that happened after the PEEP was modified. Right? So if after the PEEP was increased, the patients had an increase in their PF ratio, then you can see that the mortality declined, and this was a significant decline. This means that if increasing your PEEP is leading to better oxygenation, leading to better lung recruitment, then these patients will have a lower mortality as compared to patients if you had not changed the PEEP. On the other hand, if the PEEP is lowered, or if the PEEP is lowered and then the PF ratio is increasing, again the mortality is declining. Therefore, there is a scenario, there is a strong case that we should try and set the optimal PEEP, because if you go towards the optimal PEEP, your PF ratios will increase and there will be some difference in mortality that you will be expecting, right? If the PEEP increases, PF ratio increases, it's good to increase the PEEP. If the PEEP decreases, the PF ratio increases, it's good to decrease the PEEP. Therefore, you have to set the optimal PEEP. So finding the ideal PEEP is a very, very difficult thing, and we do not know what actually an ideal positive and expiratory pressure is. What we try to set is the optimal PEEP, that is to do benefit but reducing the harm at the same setting. So we know that if we give the patients a lot of positive and expiratory pressure, it will lead to decreased venous return. It will lead to decreased venous return. It will lead to hypertension, decrease of preload. If you increase your PEEP too much, it will lead to over distension and increased dead space, and that can lead to increased carbon dioxide levels. So there always has to be a balance between the pros and the cons of giving higher PEEP. So how do you set your PEEP? So there are a large number of methods. Some methods are available in only some ventilators and some are available across all ventilators. So the most important and the most commonly used method, and the one that all of us can use on almost all our ventilators, is again the driving pressure method. So as we just saw, a raised driving pressure actually means a low compliance state, right? A raised driving pressure means that the compliance of the lung is low. So now the compliance of the lung can be low because of two things. Either the amount of lung available for ventilation is low, that is the lung is not recruited, a portion of the lung is not contributing ventilation, there is under recruitment, or the second possibility could be that the lung has been over distended, and because of this the compliance is low. We are all aware about this physiology curve that we used to see, that was the volume versus pressure curve, and we used to plot this curve like this, right? So when we talk about the lower lung volumes, that is the lung is not recruited, again an increase in pressure is not linked to any increase in volume, that is a poor compliance state. In the center is where the compliance is good, and when we over distend the lungs, again the compliance becomes poor. So these two possibilities remain. So if what we are trying to do is we are trying to recruit the lung, so if you add PEEP and your driving pressure decreases, that is the compliance increases, this means that you're actually recruiting new lung, and this is going to do benefit to your patients, and therefore you should try to increase PEEP. But if you increase PEEP and your driving pressure actually increases, this means you're just over distending the lung and you're reducing the compliance, and this high PEEP is not going to benefit your patients. So the driving pressure is an easy technique to set your optimal PEEP. The way we do it is whatever baseline PEEP we have set, we increase the PEEP by a value of 4 and then we measure and record the driving pressure. If your driving pressure decreases, then you further increase your PEEP and again look at the driving pressure and you keep increasing the PEEP till either your driving pressure becomes unchanged, that is, there is no difference in the driving pressure, or your driving pressure actually increases. If your driving pressure remains unchanged, then you are somewhere near your optimal PEEP. If after increasing your PEEP, the driving pressure actually increases, this means you have done some harm. You have to dial back to the lower PEEP and then try to decrease the PEEP and then see if the patient is still having an improvement in their driving pressures. So the ultimate goal is to reduce the driving pressures and to keep it less than 15. So the common question that people ask is, after changing the P, for how much time should we wait to calculate the driving pressures and before taking on the next step? So changes can start as early as a few minutes to 10 minutes, but the complete change or the complete change in driving pressure, the improvement in the oxygenation can take as long as 1 hour. So it's preferable that you wait long enough, that is 30 minutes to 1 hour, to see your changes in your driving pressure before experimenting with your newer value of PEEP. The second method to adjust PEEP is known as the recruitment to inflation ratio. This is a algorithm that is available only in select ventilators. In most of the ventilators, this is not then the Draeger ventilators as of now. So what recruitment to inflation ratio means is that if suppose the patient was at a higher PEEP, so what the ventilator does is that it reduces the PEEP, for example, from 15 to the PEEP of 5. So when the PEEP decreases by 10, there will be some extra amount of volume that will be exhaled, right? Apart from the normal tidal volume of the breath, there will be some extra amount of volume that will be exhaled. This extra amount of volume is coming because of two reasons. Two reasons. The first reason is at a level of 15, all your alveoli were bigger, right? At a level 15. If the pressure is dropped from 15 to 5, your alveoli are going to get smaller because the pressure, the transvalvular pressure is decreasing, the alveoli are going to get smaller. So because of this change in volume, some amount of volume will definitely be exhaled. This is known as the predicted exhaled VT. But what if the pressure is changed from 5 to 15 and instead of just shrinking, this alveoli actually completely collapses. It becomes, it de-recruits. Then the amount of volume that will be exhaled will be much higher than your predicted volume, and this is the actual recruitment volume that has come out. So what we look at is the amount of exhaled volume. We try to compare it with the predicted volume, and if the exhaled volume is much larger to the predicted volume, we can say that we have de-recruited the lung. And this is known as the recruitment to inflation ratio. That is the compliance of the recruited lung to the compliance of the respiratory system. The ventilator itself gives you this value. You do not have to calculate it. And we say that a recruitment to inflation ratio of more than 0.5 suggests high recruitability, and we should target higher PEEP for these patients. Another concept is the airway opening pressure concept, which is close to also what we know as the lower inflection point. Again, there are only certain ventilators which will give you this pressure. They themselves run this algorithm and give you this pressure. So we know if the pressure is increased from 0 subsequently till a certain point, the volume of the lung will not increase because the lung is collapsed. And after a certain point, the volume suddenly starts increasing very fast. That is the point where the lungs have actually opened up and the compliance of the lung has improved. So this point is known as the lower inflection point or the airway opening pressure. And you should set your PEEP somewhere close to this lower inflection point or airway opening pressure. Remember, these curves can only be plotted at extremely low flow states. We get similar curves for our patients who are on ventilators who are getting high flow. Under high flow, these curves cannot be used to predict your lower inflection points. They will not be a true estimate. We also have a newer modality now that is known as the electrical impedance tomography. It's a relatively newer tool, and I don't think so many centers have it. We were fortunate to have it in our ICU when I was working at the Department of Pulmonary Medicine at AIMS. So what this technique is it in this machine, this is a machine almost looks like a ventilator. You attach multiple electrodes to the chest of the patient, and across these electrodes, electrical currents are passed. And by the passage of these electrical currents, what the machine does is it estimates the amount of air and it estimates the amount of tissue inside the thoracic cavity. This is working on the same principles of bioimpedance, the same ones that we use for body composition analysis. In the same way, this machine helps to tell us which parts of the lung is having air, which parts of the lung is having tissue, and what is the change that is happening over time. So it is giving a real time change amount of the amount of air getting in and getting out of the lung, that too in a regional fashion. So this is how the machine looks like. It Every breath can be seen in real time, and this is how the machine displays. So this is just like a CT image, and the blue regions are the regions that are getting air in and out with every breath, and the white regions or the black regions are regions where there is no change in the conductance that is happening over breaths. This means that these regions are not getting any air. So the blue regions are ones that are getting air at every breath, and the black regions are the one which are not getting air at all. So this machine helps to give us the regional ventilation. So once we have an estimate of the regional ventilation, we have an estimate of the functional lung volume that we have, and therefore these machines can help set us the VT. What else this machine does, it helps us to set the PEEP. So as you can see, the patient was given a staircase maneuver. The patient was given a PEEP of 24, and then it was slowly declined from a PEEP of 24 to a PEEP of 10. So what this machine will give us is, it will give us two values. One is the loss of compliance at high pressure. So this orange regions actually represent those parts of the lung which, when they were subjected to high pressures, they actually had a decrease in compliance, and this was because of over distension. So as you will expect, when the pressures were high going from 12 to 18, the ventral portions of the ventral portion of your body, that is the parts which are not involved in ARDS, actually start getting over distended, and their compliance actually decreases. On the other hand, if we talk about the lung bases, then the gray portions represent those part of the lung which have low compliance at lower pressures. So if you go from a pressure to 18 to a pressure of 11, you can see that the gray portion is increasing. That is, there is loss of compliance happening at the bases at lower pressures. So we get two curves. We get the orange curve and we get the gray curve, and where these two curves intersect is the region where we have a balance between recruitment at the bases and a balance with the over distension at the apex that is happening, and our optimal PEEP, not the ideal PEEP, our optimal PEEP is somewhere close to where these two curves are intersecting. So if we have EIT, we can use this to set our optimal PEEPs. The last concept of setting our optimal PEEP is the stress index. So the stress index is again very simple. This is the pressure values versus volume graph that we just saw. We're actually inversed and seen. So at lower lung volumes, the compliance of the lung is low. If then the lung volume reaches a particular zone, that is where the compliance is the maximum. And at higher lung volumes, again, the compliance becomes low and the pressure increases much more fast. So when our patients are getting a constant flow on the ventilator, then the pressure versus time graph is almost equivalent to the pressure versus volume curve, because there is a constant flow. So with passage of time, slowly and steadily the volume at the same rate will increase. So your pressure versus time graph is actually just similar to the pressure versus volume graph. So if suppose your pressure versus volume graph shows a slope like this, that is, the compliance is actually increasing as the time is passing, right? The pressure was rising faster initially, and as the tidal volume is getting delivered, the pressure rises more slowly. This means that the compliance is getting better. For the same amount of change in lung volume, the change in pressure required is much low. This means that you're operating somewhere over here of the graph. This means that your functional lung volume is actually low and you can add more PEEP. On the other hand, if your pressure versus time graph actually shows a curve like this, that is convex upwards, this means that as the volume is increasing, as the time is passing, the pressure starts rising much more rapidly. This means that you're operating somewhere here on the pressure versus volume graph and your lungs are over distended, and therefore you should reduce either the PEEP or you should reduce the tidal volume. You have to improve the compliance of the lung. Whereas if your pressure versus time graph actually shows a straight line, it's either bending forward or upwards, that means that you're operating somewhere in the center, that is the region of the best lung compliance. So the stress index is a very simple tool that we can use at the bedside with the help of a naked eye to decide or to fine tune our PEEP settings, whether we need to increase the PEEP, decrease the PEEP, or leave the PEEP alone. Coming to the last goal, as we saw, was to minimize the ergo trauma. So we have set the optimal PEEP, we have reduced tidal volumes, we have reduced the transpulmonary pressures. The last thing is to minimize the trauma. And this minimize the trauma means to minimize the respiratory rate. This is something that we sometimes forget in our overzealous attempt to keep this value of CO2 normal, we end up damaging the lung. So you're doing no good to the patient by bringing down his CO2 values to an accurate value of 40. Even if the patient has a value of 50, the patient is not going to undergo any harm. But if you try to target a normal value and you end up increasing the respiratory rate too much, you will end up causing trauma to your patients. So remember, minimize your respiratory rate. Your target pH in ARDS patients should be just more than 7.15. If the patient is having shock, then you can target a higher pH of more than 7.25. But permissive capnia, hypercapnia is allowed. And this is just not applicable for patients of ARDS. Even when you're ventilating your patients with of bronchial asthma or you're ventilating your patients with COPD, your aim should not be just to bring your CO2 values normal. Your aim is to reduce harm. The patient will eventually wash out his CO2 once his lung condition improves, the bronchospasm goes away. But if you have tried to bring it down to normal very fast by increasing respiratory too much, you will end up causing permanent lung injury. So there are variable cutoffs that has been used for estimating what the value of mechanical power should be kept. When studies were done in non-ARDS patients, they saw that a value of more than 17 was associated with harm. Therefore, a value of less than 17 should be a target. When we talk about ARDS patients, again, there is no definite cutoff, but in one study, a value of more than 22 was shown to be associated with increased mortality. So the simple rule of thumb, you can try to keep your mechanical power of to less than 17 in your normal patient and less than 22 for your ARDS patients. So I'll just conclude, change your focus and change your goals. So this is a very, very interesting picture from the ARDS net trial where they have plotted the PF ratio against time and they have compared the two groups. So what we can see is that when we look at the 12 ml per kg group, that is the one with the black dots, these group of patients actually had a better PF ratio after starting the study on day 1 and day 2. So I'm very sure that everyone would have been happy, oh, that we achieved a better PF ratio, our patient has improved. But we all know what the ultimate outcome was. These patients had a higher mortality. So what we worry about on a day-to-day basis is we worry about the PO2 values, we worry about the saturation, we worry about the CO2 values, we worry about the P peak. But in fact, what we should be worried about in our patients is we should look at the transpulmonary pressure, we should look at the plateau pressures, the driving pressures, we should try to set the optimal PEEP and try to reduce the mechanical power. So the takeaway points from my lecture would be the first rule of medicine is always do no harm. So if you are not aware about ventilator-induced lung injury and you're just ventilating your patients without applying your brains, just looking at values of PO2, PCO2, you are harming your patients and you are not following the first rule of medicine. Your ABG targets are very important. We have not discussed about what is the optimal level of SpO2 or PO2 that we should target, but just for completion's sake, FIT5 to 80 is the most commonly accepted norm. Minimize your respiratory rate, even if that means tolerating some hypercapnia, that is okay. Keep your transpulmonary pressure or your plateau pressures less than 30. Remember, in obese patients or where you expect stiff chest walls, a value of more than 30 might also be okay. Keep your tidal volumes to less than 8 ml per kg and then fine tune it with delta pressure, that is a driving pressure, because it's a representation of your end expiratory lung volume. Lastly, PEEP. It might be difficult for us, to do these methods of setting the optimal PEEP, even looking at driving pressures. So the simple thing that I would tell everyone is you look at the PEEP FiO2 tables. If your patient is having mild ARDS, then there is no point of going with a high PEEP. You start with using the PEEP FiO2 tables and then you fine tune your PEEP by looking at the driving pressure or by looking at the stress index. So fine tune it with the help of the stress index. If you have advanced technology like electrical impedance tomography or ventilators that give you the recruitment to inflation ratio, that's going to help you set the optimal PEEP. With this, I'll end my talk. If you have any questions, I'll be more than happy to take them.
Thank you, Ayush. Awesome. As expected. So before really going into the questions, I would like to ask Dr. Sryma for any comments or any clarifications or anything else you want to add, ma'am. Yeah.
Right, that was an excellent presentation, very lucid talk, explaining the nuances of diagnosing VILI, and he explained very clearly even for beginners. I think you would be able to understand the various complicated mechanisms. So very nice presentation. Just couple of things I would like to add. Uh, what he said is perfectly right. Like PPFiO2 table is what, even because even the advanced methods do not have any evidence in terms of prospective data, in terms of mortality. So PPFiO2 table, you can start from there. Now, regarding recruitment to inflation ratio, it can be done on all ventilators. You do not need, the algorithm. If you Google, there is a website called RT Maven. I thought it is better to say the website because, they have put up videos on how you can measure on every ventilator. Right. So RI can be used practically. It will just take 2 minutes of your time and it can be used. But the problem with recruitment inflation ratio is that the cutoffs are not very well defined. And another problem is that, as he already said, the effect of PEEP is actually, it doesn't come with a single, within a minute or even within 1 hour. When we do proning, we know that the effect of proning on recruitment and on PF ratio takes up to 16 hours. Or, so the benefit takes a lot of time. So the individual PEEP titration using plat and driving pressure, that may not reflect the actual thing which is happening. So that is, and also that titrating the PEEP with driving pressure, the caveat is that once you change the tidal volume, the plat changes. So if you're increasing your PEEP, if you bring down the tidal volume, you can still keep the driving pressure, manipulate it. If you change two variables, then it will anyway change. So, and there is day-to-day variation in all these things. So single method may not be correct all the time. Recruitment inflation ratio is useful and can be done. So that website which I talked about, the RT Maven one, that has videos on how you can do it on a servo ventilator as well, Mackay, as well as everything. So, but only thing is that patient has to be passive. So it is all applicable in a paralyzed patient. So that is one thing which I wanted to add. And yeah.
Are you calculating RI in your patients, ma'am, routinely?
I have done in a few patients in whom, we were not able to get, I would not say I do it routinely, that would be wrong. So I routinely do only PPFiO2, and if the patient is not improving, then I try to calculate if I'm if it is a low recruitable and I'm doing high PEEP. So it is in fact more useful to find out if you're harming the patient. So rather than an RI of, 0.5, using it to identify patients in whom you can use a higher PEEP, I have found that it is useful to exclude patients in which higher PEEP would not be useful. So yeah, so that is.
So we tried to do it a couple of times, but you have to kind of drop the respirator rate by like 5 or something, where
yes.
patient suddenly becomes a little agitated and.
So no, so that's what it has to be done in a passive patient.
Paralyzed patient, yeah.
It
So,
is
but the
only so
patient, they
what
start
you can do.
desaturating in between.
Yes. So it has to be done in a passive patient only. So what you can do is, like, if you are in the first few days of ARDS, most of your patients would need paralysis. If you're proning, for practically speaking, you would need to paralyze. So, so in that point, you can use it. So it is useful only in a paralyzed patient, not in the other patient. So once a patient is continuously breathing, obviously all these none of these menus work. So yeah, that is it.
So all these things will actually tell whether the lung is recruitable or not, but how do we set that first initial PEEP, especially patients who are a little bit hemodynamically unstable? and ARDS. So when we are sitting on the ventilator, you usually following in your routine practice? Like what is the initial peak which we will set in a
That's a
ARDS?
very good question, because most of the time we forget about the hemodynamic effects of PEEP. Like we are thinking PEEP only oxygenation, but you have to think broadly. So that is very apt. So as I said, PEEP FiO2 table is the starting point. If a patient is in like shock, obviously I wouldn't put directly a high PEEP, even if it is a severe ARDS. So you would first stabilize a patient. I would start with low PPFiO2 table, stabilize the patient, and do rest of the things. And generally, in first few hours, if the patient is not going to improve, and most of our patients have a usual normal BMI or a lower BMI. They are not very obese, in which you can safely give a high blood pressures Dr. Ayush already said that if it's an obese patient, your plateau pressures, you can be a little bit liberal, because you're thinking that your chest wall is also playing a role. But most of our patients are not that. They're either malnourished or thin built, in which you know that the chest wall is not doing anything. So your plateau pressures are most likely what is the transpulmonary pressures, because the patient is passive. So I start with PPFiO2 table, and I don't go with high PEEP right away if it is hemodynamically unstable. Then I have used recruitment inflation ratio if the patient is paralyzed. But as I said, I use it only to exclude patients in which I do not want to use a high PEEP, not to set the PEEP as such. And another thing which may be useful is lung ultrasound. So there is something called as re-aeration score, in which you can give a higher PEEP and see the lung. So that's also something you can find out. There are articles on it in which you find out the ultrasound, the scoring, which is like if it is fully consolidated versus few B lines versus a normal appearance. So that is another thing which is useful, but I do not do it routinely. So what I feel is we start with that PEEP and see how the patient is improving as a whole. So if your oxygenation is improving and your driving pressures are sort of okay, then I don't do any of these extra things. If the driving pressures, I'm not able to control the driving pressures, and if the patient is not improving, I feel the safest method is proning. And because that is that takes care of a lot of your things. Your baby lung gets bigger, so I mean, you get a safer level of safer type of recruitment, safest I would say, because recruitment manuals are out. High peep also a lot of barotrauma, so proning takes care of a lot of things. So my first thing is proning rather than doing any other extras.
I would also like to ask you, when the patient is with the ARDS, sometimes we try to put them on HFNC or NIV. So when we should not actually go for NIV, when we can use HFNC, or when we should directly consider intubating the patient.
Right. So HFNC versus NIV, there is not much data. There are some trials which say HFNC is marginally better, some things which say NIV is better. And overall, in moderate or severe ARDS, obviously it is a very difficult question. So, but I would say, practically speaking, in some ARDS in which you're thinking the patient will improve, you wouldn't want to intubate right away, seeing these, the rates of ventilator-associated complications which we see, especially VAP, like if you have a scrub typhus or something in which you know that the patient will get better. So those scenarios in which you know that the patient would get better, like if COVID was there, you know that this patient would
Yeah.
have a prolonged course. So yeah, that is one thing. But the most important thing on HFNC and NIV is to see how the patient is breathing. This is practically speaking how I have made a decision, because a patient who is very having too much respiratory effort on HFNC or NIV, they are going to worsen. So it's very important if you use either HFNC or NIV. There is nothing head to head as such, but I prefer HFNC for the comfort and tolerability. But again, any non-invasive methods, if the FiO2 is going above 60 to 70, you should be very, very cautious and watch the patient very closely and see how they are improving. Because it's not sustainable to keep a patient on a non-invasive mode if the FiO2 is above 70.
Yeah.
Practically speaking.
Dr. Ayush, what is your practice? Take the patients on HF and CNIV, or what is it? Hello?
So, like
I think
ma'am
he's
mentioned, if the
Yeah.
FiO2 is more than zero point 0.6 and zero point 0.7, I would like to tilt in favor of mechanical ventilation. The reason being that these patients already have such a poor reserve. Once the FiO2 crosses zero point 0.7, we are going to land up with peri-intubation problems. You will not be
Yeah.
able to oxygenate the patient, and the apnea time that you will get to intubate is going to be so low that you will inevitably lead to somewhat of your peri-intubation arrest. So most of your peri-intubation arrests that actually happen is because we had actually delayed the intubation too much. And we saw this happening during COVID times when we waited for the FiO2 to be more than 0.9. So in my practice, if the FiO2 is more than zero point 0.7, and I actually also use the ROX index, I think it's a very good tool because it looks at both the FiO2 being delivered and also looks at the respiratory rate. And this should be the true respiratory rate, not just a glance at the patient, how iska rate zyada hai. True, you need to see the patient, how he's breathing. And if it's actually your ROX index values are good, your respiratory rate is declining with HFNO, then you can wait. But if the patient continues to breathe rapidly, has tachypneic, you should go ahead with ventilation. What we have not discussed is self-inflicted lung injury. That's also a thing. When the patient is breathing spontaneously, he is injuring the lungs, and these lungs of ARDS patients are already very damaged, and we should be cautious about it.
So this is
Just
what I wanted to
another
ask.
point
Yeah.
I wanted to add is that, when people put patients of ARDS on NIV and they see 600 ml tidal volume on a PS of 6, they are very
Huh?
happy. So that is
Lung
something which
confidence
you
will
should
go
be
down.
very, very, very cautious about. Okay, you should be
Yeah.
actually worried if the patient is generating that tidal volumes. So some people, they just see that, wow, very high tidal volumes, you can reduce pressure support. So that is a very big fallacy. So if you are seeing high tidal volumes on NIV, then that means that patient is going to fail NIV.
Yeah.
That
That
is
we
also
keep
one.
seeing in pressure control also. Patient not deeply sedated, having a lot of effort. And pressure control with low
Oh,
pressures also when the
I'm talking
volumes are
about
high.
non-invasive right now. No? We were
Yeah.
discussing
Yeah.
about
Yeah, ma'am.
non-invasive. Yeah.
Yeah.
That
So
is
the
also
same thing we see in patients in PCV also, where the patient is having a big effort. People think that the compliance has increased better. It is
yes,
getting
yes.
better because the volumes are high. Yeah.
That is
Mm-hmm.
the precise reason why I mentioned what is the pressure that on the ventilator actually represents, because it's not factoring the patient's active efforts. So we see patients in even a volume control mode, the patient has a pressure of 30 one day and the next day it's 25. All of us are happy. But if you look at the patient is gasping, but the
Right.
pressure
Yeah.
of the ventilator is low. So that is not a true
So,
representation. That
yeah.
has to
You
be
see,
taught to everyone who is just starting to deal with critically ill patients on ventilators.
the importance of clinical examination and critical care. That's what I actually stress here. You look at the patient, put your hand on the patient's abdomen. Then you can actually identify a high respiratory drive. A patient comfortably breathing versus, that is the easiest way. But another thing which can be used is, if the patient is on pressure support and actively breathing, you can do actually something called as, measuring the PMUS. I think, what you can do is give an inspiratory pause. I don't know whether I'm clear. That is one way you can identify a PMUS on a patient who's spontaneously breathing on pressure support. So
You're
just
referring
like
to
you mentioned,
P.1, ma'am?
P 0.1, I think, ma'am.
no, we are not
3.1, yeah.
talking about P.1. So what I'm
Okay.
talking about is, if a patient is on pressure support,
Uh-huh.
okay. So pressure support, or even pressure support, if you have put a PS of 5 and PEEP of 5, your peak pressure would be 10, right?
Yeah. Hmm.
But your plateau pressure can still be measured on pressure support. Some ventilators do not allow for a plateau pressure maneuver if there is active effort, but these days most of the ventilators do allow that. So if you measure plateau pressure on pressure support,
Mhm.
right. So what happens is actually it will be higher than the PS plus peak. And that is
Okay.
one way you can, yeah. So that is also there. That's called as a pressure muscle index.
Oh, this is very
Yeah.
interesting. Yeah.
That's very interesting actually. So that is how, so you give an inspiratory pause end inspiratory pause, just like you measure PLAT. So you actually see the graph going up.
Yeah.
So yeah. So the PLAT pressure on PS will be higher than P peak. That's exactly what Dr. Ayush said. That is the that is the respiratory drive or the respiratory muscle activation.
Of the
And
patient.
there are
Yeah.
cutoffs of that also. So if you read up about it, it's interesting. So how to
Which
measure?
ventilators allow to do this, ma'am? Like plat in patient on pressure support usually.
You can do it on Avia, I've
Yeah.
seen, and yeah, I don't know about Mackay. I have not tried it on Mackay. I think
Yeah.
it doesn't. It detects active pressure, active breathing, and then it doesn't pause. Some ventilators do not.
Yeah.
So you can try it if yours does.
So there is one question in the chat box by Dr. Anita. What should be done for diaphragmatic protective ventilation? And are those to be included in patients being ventilated? Dr. Anita, you can actually unmute yourself. Uh,
I think what the question means is
yeah.
just preventing self-inflicted lung injury and preventing diaphragm dysfunction. So there is nothing which has actually looked at how diaphragm function can be preserved. So most of the time, if you do a lung protective ventilation, that should take care of that as well. So,
Okay.
and controlling the respiratory drive is what is important
Yeah,
in
this is
that scenario
another
as well.
thing. Like Ayush, you said it is a patient-inflicted lung injury, but it is not fair on the patient's part to label the lung injury because of the patient's efforts. So they will have high respiratory drive. So can you tell us
Right.
about how to control that
Yeah,
high respiratory drive?
yeah, that's a very good point again. Like you are not actually you shouldn't be blaming the patient for something you cannot do.
Yeah, so
So
I think here the importance of learning about the right sedation practices in the ICU come into importance. And sometimes what we deal with is we just try to give the patient benzodiazepines, midazolam, and propofol, but we do not look at the drive. So the reason for the high respiratory drive is not always related to the lung. The patient has so many tubes in situ. The patient might be having pain. He might be having a temperature and so many other things. So I think looking at all those things, reducing the pain, giving adequate analgesia is also very important. And these things in most of our patients we are able to reduce the drive. It's just so we have seen ARDS patients with very, very bad lungs who are easily sedated with minimal sedation also. So it's just not the lung that is responsible for the drive, it's a lot of other factors which we have to deal with appropriate analgesia and sedation. So I think that can take care of the drive in most of our patients.
right, that's very true. I think there was some recent trial in which they applied HFNC to ventilated patients, to reduce the feeling of dyspnea.
Oh,
Yeah, so I think that is too much. We are not in that economics in which we can spare two devices on one patient. But I think Dr. Ayush was right, like analgesia and, using other agents which we do not generally use, propofol and ketamine.
yeah.
Ketofol sedation, that is very like better than benzodiazepine, I would say, in clinical practice.
You are using ketofol in your ICU, ma'am?
I have used during COVID because
Yeah.
COVID patients somehow had very very high respiratory drives in spite of there would be no pain, there would be no fever, nothing else which you could correct, but their respiratory drive used to be very high. The severe ARDS. So such patients, propofol is actually very good in reducing respiratory drive. And I think recently remifentanil has come to the market in India, but I
Remifentanil.
I, I do not have access to that right now. So
I
How it
that
don't
is
use
is
different from
remifentanil
fentanyl,
for
remifentanil?
these settings, but my anesthesia team is actually using remifentanil when I'm doing bronchoscopy. So it actually does reduce the cough and it reduces the drive of the patient. So I'm sure it
Uh,
would be
it is just
working well.
it's an opioid, no? It
Yeah,
is like the way you
yes.
use
But the
fentanyl, but
titration they are getting is actually very good.
yeah. So remifentanil, it is very short acting, no? So if you use
Yes.
fentanyl, you'll have to wait for a long time before the
Yeah.
patient can breathe on their own. So, but otherwise, and practically speaking, for ARDS ventilation, I feel ketamine with propofol is best because propofol can, reduce the drive. You can titrate it up, and ketamine will take care of the hypotension of propofol. And I
Uh,
feel as critical care people, no, we shouldn't be worried about giving a little bit of NORAD to facilitate proper fall. We know it is not shock because of sepsis. So
yeah, yeah. So Ayush, if you have calculated a patient's mechanical power in ARDS, and if it is like 25, what will you do? You will come down on respiratory rate or tidal volume?
So honestly speaking, I've actually never used calculation of
Uh,
mechanical power in my clinical practice. I think the more approved concepts that have been there for a longer period of time need to be looked at first. So obviously look at your driving pressures, look at your plateau pressures, and after that, even after that, if suppose you feel, and if you obviously, I think the ARDS net protocol is a very valid protocol, and if we are able to use it correctly in most of our patients, we are doing justice. And it also states that you have to reduce your respiratory rate even if that means your pH is dropping, so that is actually reducing your the mechanical power. The value that we use at the RR should be less than 35. That's actually because they want to reduce our mechanical power, just that the concept of power was not there, but actually they were using the same concepts of physiology there.
So it became very easy with ChatGPT. Like my resident is putting all the values required and is calculating mechanical power and giving me a
Correct.
value that this mechanical power is I what to do.
it's an
Yeah, I agree.
interesting
So
concept, but like
yes.
Dr. Ayush said, we have to first focus on basics, which has
Yeah.
been, proven. And
Yeah. So in most of the trials which we see with ARDS, high CO2 is always associated with like mortality, probably because of the pulmonary hypertension and also how true is this permissive hypercapnia, like especially in a patient who is little bit not stable hemodynamically?
I think these are two things. I think permissive hypercapnia is, it means that you're allowing the patient to be slightly on a higher CO2. The thing that you're talking about is basically the patient is so bad, the lungs are so
Mhm.
bad, they're not able to wash out the CO2 at all despite your best attempts. So there is a
Yeah.
distinction
So
here. So I
got it.
think
But
the
physiologically, don't you think like CO2 will cause worsening of pulmonary hypertension?
so
so see,
again,
this cutoff is not for patients who have already existing pulmonary hypertension, or like permissive hypercapnia is not to be used in that scenario.
Okay.
So, that is why inhaled nitric oxide is one of the rescue therapies in ARDS, and because
Yeah. Yeah.
INOX also we have used it. It does improve the PF ratio, but it doesn't
Mm.
improve the outcome.
it definitely, we use it in a couple of patients. It actually, it does improve, but the only thing is that the effect wanes away very fast. Even on the second day, the effect on the improvement in PF ratio actually completely went away. So it's just for a
Right,
rescue
right.
measure till we could have arranged the ECMO for our patient.
ECMO, right, right. Very true.
So the last question I want to
So
ask
see,
both of you.
Dr.
Yeah.
Praveen, another point which you told about, managing pulmonary pressures. This is
Mhm.
one subgroup of patients in which a pulmonary artery catheter would actually help.
Well,
You
I
know,
have never done that. Swangans you're taking.
yeah, Swan-Ganz.
Yeah.
The
So
amount of hemodynamics data, and then you would know actually what is the cause for everything. So,
yeah.
there is a subset of severe ARDS patients in which I feel there is still, scope for pulmonary artery catheter.
By the time I joined residency, it already became obsolete. So I never had a chance
Yes,
to.
yes, 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 true.
Yeah.
Same in
Yeah.
my case. So I
Yeah.
am learning about it now.
Yeah. So I want to finally ask one last question. Have you ever diagnosed your patient, written in the case file that this patient is ventilator-induced lung injury?
Barotrauma, obviously, I think every one of us would have written. Pneumothorax, pneumomediastinum. So
Uh-huh.
that is
Yeah.
pretty common. Once you ventilate ARDS, especially whoever has done mechanical ventilation during COVID.
Yeah. Sure.
So yeah, the other form
Okay.
of VILI in which there is no barotrauma, obviously no, because it is very difficult to, the population who gets VILI are the population of ARDS, whom it
Mm-hmm.
is just like ARDS, like Dr. Ayush told, it is just like ARDS. There is no way for you to know whether it is VILI or unless you do a CT, which is
Yeah.
impractical.
Yeah.
So other than barotrauma, I don't think anything gets labeled.
I think it's always going to remain in the waste basket category of VAC, where we know that there's no infection, but there is some deterioration. We're not sure what it is. We'll never actually label Willy. most important, because we know that we are labeling ourselves as the culprits. So, but we should
Yeah.
be aware and try to reduce harm as much as we can.
Yeah. So I think there are no more questions. I thank both of you for this amazing session. I have really enjoyed it. So we will meet in some other day with some other topic. Thank you, Dr. Ayush and ma'am.
Thank you, sir.
Thank you.
Thank you so much for
Thank you
giving us
for
this
making me a
opportunity.
part of this. Thank you. Bye. Good night.
Good night, ma'am.